Welcome back. A little change. The next panel will be in English after all because Marek Krajci couldn't make it today. But it doesn't matter. We will have a quality discussion anyway. Štefan Korec, Chief of OnkoAliance Slovakia, will have a presentation. Please.
Thank you very much.
Go on.
Well, good morning again, and thank you for your patience and staying here. Pardon? Well, okay, now it's okay. Good morning again, and thank you for your persistence and staying here for further continuation of the conference. We've heard a lot about the plans, how we want to do it, about the programs, what we want to improve, how we want to proceed. I'm a clinician, and as a clinician, I'd like to go more down to earth and more down to real life. Okay, can I get them? I'm sorry, next slide. Slovakia is consistently among the countries with the highest mortality rate from cancer in European Union. As you can see, European Union is the middle, Slovakia is on top, and as the graph demonstrates, Slovakia has almost 100 individuals higher mortality than is the EU average. Again, per 100,000 inhabitants, almost 100 individuals die more than the average, above the average of European Union. What is of interest, that Czechia, who has the similar genetic makeup, is below the EU average, and this signifies that it's not in genetics, that the problem is somewhere else. We think the problem is in the management. The more recent data produced by OECD show that cancer incidence in Slovakia is just about less than 5% higher than in the EU, but the cancer mortality rate is 18% higher. It's almost 20% more, which means that there is problem with management. Also, the 20% more means that Slovak citizens have almost 20% higher likelihood of dying from cancer than is the EU average. That's sad. We have identified several key problems in cancer care in Slovakia. They are not specific for Slovakia only, but look, shortage of physicians, bureaucratic overload of medical staff, inefficient communication between providers, diagnostic errors and duplicities, limited access to innovative treatment, insufficient funding. Of course, there are many more, but these are the key factors what we need to deal with. All these factors together are responsible for major delay in diagnosis. The time from first signs of oncologic disease to treatment initiation is 180 days in Slovakia. 180 days is half a year, which means if the patient presents with early stage of the disease, which may be still operable, by the time we start the treatment, he may be inoperable, and this will significantly reduce his chances for beneficial effect of the treatment. Means we are causing some of the problems. OnkoAliance decided to launch a project, we call it Partner, that we want to partner with artificial intelligence and shorten the time interval from 180 days to 50 days. Yes, it is ambitious project, but I think that with the help of modern technology, more importantly, with the help of physicians and participants, we should be able to achieve this goal. The slide appears to be pretty busy, but it's to reflect the complex approach to the complex problem. The whole journey starts at the level of general practitioner. Patient fills out the electronic questionnaire, Artificial intelligence helps to interpret it, helps to create a medical note for the physician, takes in the laboratory results, and creates the note, complete note, including the assessment and recommendation for further management. Now comes the physician who will say, yes, dear AI, that's your recommendation. I am the final judge to decide which way to go. So it's not replacing the physician, but it just is a partner helping the physician what needs to be done. When a physician decides that the patient is suspicious, that there is a suspicion for malignant disease, the system sends a report to National Cancer Registry and takes care of the appointment and scheduling of the patient for specialists. Again, this is one of the key problems here, to get the patient from the general practitioner to specialist. The time delay at this point is almost 90 days. The general practitioners are complaining that if they don't call the specialist and telling them, please see this patient, the 80% of the patients will come back to them, please help me, I cannot get appointment with the specialist. Again, patient goes to specialist, go to imaging. By now, we already know there are several programs with CT reading, which should also speed up the speed up the journey, and should also help the imaging personnel to process more patients and to go faster. The patient comes to, the specialist takes the biopsy, the biopsy comes to pathologist. Once the pathologist establishes that, yes, this is the diagnosis, confirms the diagnosis, system sends the report. System, I stress, system sends the report to National Cancer Registry. System is helping. There are several systems ready to help interpret the pathology. Pathologist performs morphological diagnosis when he decides genomic profiling. And again, there is AI-assisted interpretation of genomic profiling. And in the end, the AI assists clinical oncologists, medical oncologists in the decision of further management. Also, the system will create a simplified medical note, which the main medical note shows only positive findings, while in the sub-files, there are all the detailed reports, further saving time for the oncologist and for the physician, that they don't have to read the whole stack of the reports. That's what the patient is about, and these are the specific reports. Medical oncologist is the end user of the system, which means medical oncologist has the input on all stages of patient's journey, from general practitioner, specialist, imaging, pathologist. Medical oncologist tells all the participants, I need to have this, I need to have that, I need to have these specific questions answered. The whole journey proceeds within the boundaries of guidelines from ESMO, NCCN, which are modified by Slovak Oncology Society, which means that patients will get what's necessary, and hopefully we will avoid the unnecessary tests and again speed up the whole journey. Finally, at the end of the journey, the system generates a report for tumor board, which contains medical history, physical exam, diagnostic summary, and all the necessary information for medical oncologists to make appropriate decision and to say, fine, that's what we need. In diagram, it looks like this, that patient with final diagnosis, the system says yes, surgical treatment, no surgical treatment, systemic therapy, if systemic chemotherapy or targeted therapy, if targeted therapy, immunotherapy versus driver targeted therapy. On top of it, very importantly, the system will offer also supporting literature, and if there are no drugs available for agents available for the patient, if the patient qualifies for clinical studies. So this should be very strong argument for the oncologist. That's what needs to be done. And again, I need to stress, it's just a recommendation. The oncologist has his own information, has his own knowledge base, and will be the final arbiter what I'm going to do and how am I going to do it. So we believe that a successful completion of the project will address shortage of physicians because the physicians will be more productive, will reduce the bureaucratic overload, will improve the communication, will hopefully reduce the diagnostic error and duplicities. A report from United States says that 1/3 of the deaths in the hospital are due to medical errors, which is sad, but it's a reality. Unfortunately, we will not address access to innovative treatment, and we will not not improve the insufficient funding. But yes, we are hoping that we'll at least speed up the whole journey. And most importantly, we believe that successful project completion will save the lives. Will it? Hopefully. Yes, it may sound like a science fiction. It's not. The individual components of the project are already available. All we want to do is to interconnect them, to make them work in one chain, and hopefully to offer it to physicians to use it as part of their daily life. As we've heard already from my previous speakers, artificial intelligence is now becoming an everyday occurrence, and it should become an everyday instrument for the physicians. Hopefully it will. Talking to several medical societies involved in the whole journey, we found out that yes, there is resistance from the side of physicians. I'm a doctor who is going to tell me what to do. But the majority of the doctors are ready to help, are ready to contribute to further development of the system, are ready to help to improve the quality of care of Slovak healthcare. Thank you very much, everybody.
Thank you very much. Štefan Korec will be in the next panel as well. Please take the seat. Jana Bendová, former GP expert of the Ministry of Health of the Slovak Republic. Welcome.
Thank you. Thank you.
Branislav Bystrický, Vice President of Slovak Oncology Society.
Thank you.
Thank you very much. And Andre Carvalho, Senior Scientist, International Agency for Research on Cancer. Welcome again.
Thank you.
Please just hand the microphone to the person that is speaking because we have only two. Let's, please share one and speak as close as possible so people can hear you. Thank you very much. Mr. Bendová, what are the causes of slow diagnosis in oncology from the perspective of general practitioner? What are the main problems in this whole journey that we have seen?
We have several problems. The main cause is, I think, that we need help. We need help with this bureaucracy overload, either the finances for assistant or virtual assistant, artificially intelligent, who helps us to deal with all this.
What kind of help are we talking about?
This project sounds very well. I mean, we are collecting the data, but they are not structured, and they are not of very much help for the specialists because they don't see it if they don't use electronic health records. Either way, if we don't put it into the electronic system, or if the specialist is not using the electronic system, General practitioners in Slovakia proved that they are very capable with electronic systems. During pandemics, nearly 100% of GPs started to use the electronic prescriptions. And at the moment, the number of GPs using electronic sick leave is also increasing, is more than 90%. So I think, even though the average age of GPs in Slovakia is 57 years, we proved that we are able to use such assistance with electronic health records and artificial intelligence. I really think this is possible.
Mr. Bystrický, is it about sharing the information between the general practitioner and the oncologist? Is it about the journey that Mr. Korec described?
Definitely, I think so, because it's one of the things that patients experience delays. When patient comes to our clinic, I have to really fetch all the examinations. You know, the CT scan was done in another city. I have to call them, send us the pictures so we can look at it at the multidisciplinary meeting to show the surgeons, to see where is the pathology, where was it taken. It was another city again, so we have to write there, please do the genetic testing for the mutations that I require, and I have to put my stamp on it. So everything, there are delays with all these things. So when it comes back, it's 2-3 weeks pass, and we are just waiting for the results, waiting for the genetics before I put the patients for the tumor board.
But we are talking about electronization of the system for like what, 10 years now? So
yeah, but this is the daily practice. This is how we do it, because electricization is still in infancy.
So a lot of stamps and paper.
If the patient has, let's say, laboratory test done in another hospital, I don't see it. I have to repeat it. If it's not in the documentation from the GP, let's say tumor markers, we take them again. Useless, but it's true.
Duplicity. Mr. Korec, who does benefit from this chaos? Why is it still so chaotic?
I don't know who benefits from it, but I know who suffers the most are the patients. I don't think there is a benefit to this system for everybody or anybody. I think, yes, there may be this jungle may be helping some people who with speculations, maybe helping some pseudo-physicians, some people who try to use the paramedical help, not the scholastic medicine, but no, I think there are no beneficiaries, there are only losers in this system. As long as we are in this jungle, I think there are only losers here.
Yeah. Andre, how do you perceive what you have just heard about the patient's journey, and are there any examples which we could learn from in other countries?
Oh, sure. I think data is crucial. Sharing data as well, because we're talking about, from GP, primary healthcare level, to cancer center, tertiary. And this is a journey, as been put it. The IT system proposed can help with the information, but I guess need also a restructure of the referral pathway, right? Making sure that the GP knows where to send the patient for confirmation of diagnosis, and once the diagnosis is done, where to send the patient. The sharing of the data, the creation of these it takes time, right? And in screening, we have one say that's the fail-safe mechanism, meaning that everybody that's positive should not be left behind. So if the patient that has a suspicion of cancer doesn't go for the next step, somewhere in the system knows and goes after that patient, because some patients are lost in the process, right? So it's kind of this patient navigation, this referral system. As an example, during this project that we're doing is in Slovakia and Latvia. And Latvia doesn't have yet the IT system that share all the information, but they create what they call the green corridor, that once someone is suspicious for cancer or has a diagnosis for cancer, there is a number, a hotline that's called, and they help the patient to get to the next level and eventually get, to the cancer center in a very expedient way, kind of less than 60 days. So this is a possibility that can be created, that, there is a number. And we visit the place in Latvia, right, and everybody knows about the green corridor, the GPs, the diagnostic centers, the cancer center. So I guess there are mechanisms that we can improve the referral pathway and make sure that everybody that has cancer or suspicious for cancer get diagnosed in time, get for the cancer center in time, while we have this wonderful solution that we're going to take some time to get there.
So, let me ask about the hotline. So you call the hotline, and then what?
They make sure that the appointment's made for the diagnosis, and then after the diagnosis, they make sure that the patient gets to the cancer center. So it's about the patient navigation. It's about helping the patient to navigate the health system that's always fragmented, and it's complex when you go from GP to the cancer center.
Well, this sounds like a distant future for Slovakia, right? The hotline where somebody would guide you through the system.
I am hoping that it's not such a distant future, and I'm hoping that the system will solve it without having to call. We had the virtual waiting room there. As soon as the GP wants to send the patient, decides to send the patient to the specialist, send the patient just to virtual waiting room. The virtual waiting room will notify the specialist there is a patient with suspicion, and there will be a red light blinking on his monitor. There is a patient in waiting room who is suspicious. And if nobody, if the general if the specialist doesn't accept the patient, or there are usually 3-4 specialists for every GP, you are not sending just one gastroenterologist or 3-4 of the gastroenterologist to whom you send it. If none of the specialists will accept the patient, then somebody else has to intervene. Is it insurance company? Is it the organization? But somebody has to pick up the phone. Hey, 4 specialists, you see, for 4 days, the patient has been waiting and nobody reacts. So yes, we think that your hotline should be replaced by the virtual waiting room.
There was a very good point that the patient is really lost in the system. I cannot help each of my patients with a suspicion to call to the specialist. They are often not available on the phone because they are working, okay? Yeah. They're not responding because they are busy with their work. The analysis of oncological care in Slovakia shows that, for example, for colorectal cancer screening, we have a major role at the moment. We are distributing the tests, and the patients are coming, and only 40% of positive tests, the patients go for colonoscopy, and 60% is lost. They didn't make of the positives, yes. So only 4 out of 10 go to colonoscopy. Why? They are lost. They didn't make an appointment with the specialist, or maybe they are afraid. There are several reasons. But really one of them, major of them, is they do not have the appointment straight away, leaving my practice.
Mr. Bystrický, how many calls do you get from just, your circle of friends if they are desperate to find a specialist? Because I can imagine in Slovakia people know each other,
yeah,
right?
I will tell you one example from last week. Patient came to us, visited the surgeon with a new growing lesion on his arm, and he was referred for magnetic resonance, and the appointment was in September. So he came to our clinic, even though we have seen him first time, begging to see if we can do something for him. No diagnosis yet, but fast-growing mass, most likely sarcoma. And the appointment was obviously the orthopedics won't operate without magnetic resonance. They need to see which muscles are infiltrated and if it's not infiltrating the joints. So it's obligatory examination, and the appointment is September. It's a private company who has 20 appointments a day. They won't do 21 because it's not being paid for by insurance companies, and so it's a problem. So we have to juggle some of our patients and give him a sooner appointment.
The way the system should help the screening and support the patients who take part of the screening is that they should see, if I am screened and if I am already detected, I have detected some problems, yes, I'll be managed expeditiously. I have a patient now who detected, he was a highly disciplined guy, detected blood in his stool in January. General practitioner saw him in February. First colonoscopy in March. The person who did the colonoscopy wasn't able to help. Next appointment with specialist who performed a specific colonoscopy is in July. From January, he was highly disciplined. He did his fecal blood, he detected blood. July, half a year is lost. So we hope if we speed it up, that this will encourage the patients to participate in the screening.
I also see the other part of this that everybody knows everybody or is a family with, that if you have a family or a friend there, he helps you to get the appointment earlier, but the really sick patient has to wait. Okay? So this is not fair, and we really need to put on a fast track the person we have the suspicion.
Yeah, but I think that's the thing that if there is some suspicious for cancer, the patient needs to be fast-tracked. I think in the UK they have something that 2-week rule from diagnosis to treatment, so something like that we need to do in the diagnostic setting, not in the treatment setting. Let's say for us, we can in 2 weeks we can do chemotherapy, radiotherapy. That's okay. But the problem is where the patients are losing time. It's during the diagnostic process.
Well, then that next question is, so I have a displaced disc, right? It's not about me, but it's like anecdotal evidence. So, and my doctor told me that I can pay for an MRI. It was on Saturday in the morning for 300 euros, and I could get it like in 3 days. So are we moving forward to healthcare that is for rich people, that you can pay for the MRI if you have enough money, and then sick, poor people are waiting for the diagnosis? Is this the system nowadays?
I think it's the exception. Not in all centers are taking money and doing MRIs, let's say, on Saturdays, but I think there is not a political will that would show what's its standard in Slovakia and what's a higher standard. Nobody wants to say that.
Because I don't need the MRI. I was just curious about my disc, after 4 years of exercising, and I can imagine then some sick patient could have the MRI instead of me on the Saturday morning, right?
Exactly, yes. Unfortunately, you're right, Dr. Bystrický is right. Yes, you have to pay. Yes, the question was highly appropriate. Are we heading towards a system which is good for the rich? No, we should have the good baseline system for everybody. Yes, the system is not ready and will not be ready in the short future to give best care for everybody. There is just not enough money, not enough physicians. But the baseline should be for everybody. And yes, if you want to speed it up, you may have to pay, but everybody, regardless of their money or their having money or not, should have the baseline. How to establish the baseline? Branjo, you touched it.
Well, it's difficult because on one hand we have a lack of resources, lack of physicians, and also there is some cap on, let's say, on diagnostic processes from the insurance companies. How many, let's say, examinations can certain clinic do, and otherwise, about that, it's being done for free.
I would like to come back that the fragmentation of the system allows all those gaps, right? And the pressure comes. If you need 25 exams a day, not 20, and the machine is ready to do, should not be the medical insurance company that decides I pay only for 20. Because if the need is higher, negotiation needs to come. But you only can play this if you know the numbers, if you know how much you are missing. The other thing that usually, day in, day out, they're going to do 19. But they're not ready to call someone that's in July, say, come tomorrow, because, someone did not show up. And only when you have intelligence on the system that you can track the patient, that you can track the services, is that you can fill those gaps, then can help you to shortline the time line of the diagnosis and access to treatment. The health system needs to rethink how they do. decision on demand, or no, decision on payment should be on the demand needed for the population, and not, I would stop in the 20 if the need is 25. And that needs to be rediscussed.
Yeah. So, can the system, Mr. Korec, help save financial resources for the state, and not even financial, but also the personal resources? Because we have less doctors, we have less physicians. So, is this gonna help with the money and the people that are missing in the system?
Yes, the answer is strong yes. Yes, I have 50 years of experiences in 50 years of practice of medical oncology under my belt. And yes, I believe the system will help. I believe that it's a time, that the time is here, the technology is here to help. Yes, we will reduce the bureaucratic burden. What is it, 30%, 40% of your time is paid paperwork? If we can save physicians 40% of the paperwork, or just reduce it to half, it already helps. If we can save the physicians the time where they need to check for previous tests and they don't have to repeat the test, it will save the money. If we can have the unified medical note, which is simple to read and yet contains all the details, if we can have the genomic analysis, which will tell us whom to treat and how, or just go back to the standard, it will save us money. If we can improve the communication between providers, it will save us time. So yes, the system will save money, will save the time. Yes, the system will be more efficient. And yes, it will improve and increase the productivity of the physicians, because less paperwork, more physician work. Yeah, the answer is yes and yes.
Is it 40% of your work, the paperwork? Is it accurate?
Well, if you need to write request for expensive drugs to health insurance, even more than 40%. Because when the patient comes, you just write and type, all the summary of all the records, histology show this and that. You rewrite the CT scan, you rewrite markers. Are you feeling well? Okay, tomorrow chemotherapy. So yeah. And
so more than 40%.
Well, then you take the charge, and during on-call hours you do the you do the submissions for some expensive drugs for insurance companies. So.
In our general practice, we have a very recent experience. We changed the program, the software for our practice, which is based on a lot of automatization. And it's not 40% anymore of bureaucracy. So we experience it works. It can help us.
So how many is it nowadays?
30.
30.
But it's in 2 months. We are not using the system 100% now because we had to learn a lot. But I think it will be even better.
But is it optional? It's optional,
Yes.
the system, right?
There are different systems. We used one for 15 years. Now we changed because we had a recommendation. It's working this way, and it's really working this way.
So how demanding is the preparation and implementation of such system? Like, I can imagine that it will be difficult.
It's not easy. Definitely it will not be easy. But as I mentioned at the beginning, we expect about 10% of the physicians to participate. If we have 2,000 general practitioners in Slovakia, we hope that we have 200 of them to participate,
Like
especially
in the
pilot study,
Yeah.
which means the 10% of the physicians who will participate are most probably already digitally literate. They know how to use the system, so they can just go one step higher. Yes, it won't be easy, but yes, we will work with people who are not beginners. So we are very optimistic that it won't be that long. I cannot tell you exactly if it's 3 weeks, 3 months.
Okay, but except the practitioners, what other can be done in the pilot system?
Of course, the start and the main stress is on the general practitioners. They are the ones we need to work with very closely. They need to be given more responsibilities. And of course, the next step, the specialists, We know how long is the waiting time for the specialists. We need to tell them. Specialists are complaining. GI practitioners tell me, and you don't have to listen now. GI practitioners tell me, GI specialists tell me, oh, the GPs are sending just the patient GI and don't tell us anything about the patient. May not be true, but yes, the specialist will get full report of everything. He can read it in 2 minutes, which will save him time, doesn't have to search for CTs, doesn't have to search. It will save him time. And again, we need to work on the specialist to accept this unified note, which will float back and forth all the time. Next step is the pathologist. The pathologists are already starting a project of national digitalization of pathology slides, which means it's a national project which already has a European EU funding, and they are already preparing nationwide digitalization of pathology slides, which will make it much easier to subject it to AI reading. And finally, the oncologist, what the oncologists told me, several oncologists, well, if you provide us with that amount of data on one page, that's the dream. We just have to look at it and make decision, go, don't go. So oncologists, I think, that's the group which is most prepared and ready to highest extent. And as you just mentioned, Janka, I'm really very impressed by you using the new system, so I think it will be much easier with general practitioners as well.
Yeah, you probably will be in the pilot.
Sure, I already promised.
Okay, so, but definitely you will need cooperation with different fields, right? So, Ms. Bendová, what kind of obstacles do you see from your perspective in the implementation of the system?
We really suffer with a lack of staff and finances. We would need finances mainly for have more staff and also more competencies for the nurses. To be able to employ one more nurse and to employ assistant, really. We suffer much that we are doing their job because, yeah, we don't have enough finances for them. And also, we would need more competencies. Would you imagine that 3 years ago we couldn't send a patient to mammography? Preventive mammography?
Why?
It was just blocked. They had to go via gynecologists, but it was changed recently. Okay, just an example. Obstacles which I don't understand.
So what are the obstacles from the perspective of an oncologist, Mr. Bystrický, if there are any? Because Mr. Korec said that you are better prepared than the others.
Well, I think better prepared. I think the obstacles are what Janka was saying as well, that the lack of resources and stuff, but I think it's also the problem that sometimes we can talk about it, that sometimes the GPs, they say they can't write, let's say, requirements for a CT scan. They can't send the patient for a CT scan because either it's not paid or it's increasing their expenditure. So that's the problem. As for more competencies for GPs, I would vote for that definitely. But also I would vote for the GPs that are competent themselves to do it. To, let's say, prescribe medications. But for us as oncologists, I think we would welcome that definitely. If we can have it kind of streamlined, as I was saying, with all the delays and they are eliminated, I look at the labs from the other hospital, I have the CT scans at hand, which I can, download and look for the radiotherapy, let's say, that was done in some other city. Excellent. I don't have to, call anybody else to send it.
Before we get to the EI in healthcare, is there any question from the audience, please? Yes.
Thank you so much. My name is Pernilla Gunther. I'm representing the European Commission today. I'm a member of the Cancer Mission Board. I'm just wondering, since the healthcare systems are so different in different countries. But I'm just wondering, in some countries, I know, and for example, I'm from Sweden, and we have some kind of, healthcare standard in a systemized, healthcare that we know the time limits. If you get a diagnosis, or at least you have some kind of suspicion when you go to the GP, and then you're sent to a specialist and you're diagnosed, you can also see within a time frame that this and this and that will happen in a certain amount of time, and you are very well prepared as a patient. You know where to go and which kind of treatment you also will have in this time frame. I'm not sure if it's applicable in Slovakia, but I think since I'm also a former member of parliament, I'm also curious, how do you experience your demands from policymakers? I mean, it's also a question about patient safety, I would say, to really bring the patients in time to really get their diagnosis and, of course, their treatments. We will have a session later on today about how much cancer affects the society and the costs for society. But to increase, I mean, the prevention and also to listen to you as professionals and to increase patient safety will actually save money. So I'm just curious, because I think one of our main reasons to have a cancer mission board is also to be able to implement the Europe's Beating Cancer Plan. And I think the policymakers, together with healthcare professionals and patient organizations, are really important to work together to increase the implementation. It was a long question, but...
No problem. So 2 parts of the question. First is if we have any standards for waiting time for a patient, or like a journey that a patient could see where to go to. And would it be applicable in Slovak system?
Well, yes, Sweden is quite far away from here, not only geographically. Sweden is quite far away from us also in money supply. So yes, we can have standards, we can have limits, but it's impossible to apply them. What do you think?
The same, unfortunately.
Mr. Bystrický? Andre?
I'm not aware of any time limits that we have so far that would be kind of imposed or that we have to, stick to and be kind of sanctioned or incentivized. That was the other thing. If we can, that was the other thing, maybe not do it kind of, put some incentive if the patient is diagnosed sooner or if he starts treatment sooner, to put some intensive incentive to the healthcare provider for such a patients. That would be also, good.
Andre?
I agree completely. Health systems are different, but goals are equal, right? And we need to work on that. Solutions are going to be context, right? But if we don't know the data, we don't know what we need to improve. And some improve comes natural. Maybe from 180 to 50 takes longer, but maybe for 180 to 100 to 90 is achievable. Maybe in Sweden it's just 30, right? But we need to decrease that. 6 months is not the case. I'm originally from Brazil. There was a law there that 90 is the limit. Not 60 because it's impossible, but not 180. So I think the goals are the same. We need to help cancer patients to get as fast as they can diagnosis and treatment. Set the goal. Don't start, eventually in 5 years you're going to have 50 days. Just go. It's 150, then 100, then 90, and you begin to improve and look at that, what worked, what didn't work. Solutions are different.
Okay, and the second part of the question was if you get any response from policymakers. And since I'm a political reporter for my whole life, I mean, my commentary to this would be that sometimes people go to the ministry and it's too complicated to solve the problems, and sometimes members of parliament do not understand the issue. So Maybe your comments on this about the policymakers?
The support has always been declared, the political support, but the reality is different.
Is it too complicated, or what is the main problem?
I actually don't know. Maybe the reason is that the politicians change very often. The main survival of our Ministry of Health is less than 2 years, as far as I know. So the continuity is missing, and as I was the chief expert for general practice, I worked with 2 ministers, and I came with one and with arguments, and we started doing something, and it changed. So the person changed, and I had to start again with the same.
Mr. Bystrický, what about the policymakers?
I think I agree.
So continuity.
Yeah, continuity is one issue, and the other thing is that sometimes, at least the laws that are being passed are really not being discussed with the specialists, you know, and their impact are being just passed so they get some political points, and not really with what we really need in the field. You know, we need this, but it's too difficult. Rather, let's pass some other law, you know, that cosmetic law, or that we have, yeah. You know, there was a law passed recently that we have to report to the judges if we restrain the patient. Nobody knew about it, that such a law was passed, and now we have to report every day if there are some use of restraints for patient who is agitated just for a day or for a short while. That's another bureaucracy.
More paperwork.
More paperwork. And every day, every 24 hours, you report to the judge.
Cool. I didn't know about that. Andre.
I would like to stress what you start is communication, right? I don't think we as specialists, highly specialized, are ready to deploy the information that the policymakers are ready to read and listen, right? As a scientist, I would like to show survival curves, p-values, and half of people will not understand what I'm talking about here. And I remember I was with the CEO of my hostel once. We got an audience with the Minister of Health, right? And I was there as a technical, and I began to put this, and my CEO said, stop, because the minister got lost, right? And then he said, let me start it again. To the minister, he said, you can save lives, right? Let's see how. It's kind of, we are not prepared, and we also need to do our homework when we have a chance to talk with the policymakers, how we talk in a manner that they understand their role and their importance in the system.
Mr. Korec, policymakers?
Yes, policymakers. I'm still looking at our Mrs. Dolinkova here, who is the representative and hopefully will be one of those key players in the future. We had a Minister of Health who is highly highly committed to help. We've heard him.
Yeah, but he's leaving in 6 months.
Yeah. Well, that's fine. That he should give the message to his, hopefully, next guy who comes in line. But yes, it is one of the reasons of having these conferences, to have people here from patient organizations, physicians, international organizations, and we thank you all for coming here to Bratislava to support us, is to make the system, make the politicians aware of the problem, of need to address the problem and need to help. Yes, the pressure is mounting. Yes, many political parties have the healthcare as an issue or number one or top of the issues in their political programs. So we are hoping we'll just keep building the pressure, and we are hoping to get more help. And I am really hopeful that the future government will be really supportive.
Yeah, well, pity that Marek Krajci is not here, because he could have done something as a Minister of Health. He didn't do that much. Okay, but COVID was there, to be fair. Another question? Yes?
So hello, everyone. My name is Jana. I'm the Managing Director of MSD Slovakia. And first of all, I would like to salute the presentation of an AI-powered patient journey potential project. I think this is really great. And while Sweden is a little bit further away, I think Czech, Poland, Romania, Bulgaria, they're quite close to us. And I know for a fact that they're already looking at very advanced projects to utilize artificial intelligence to optimize patient journey. So I had a very similar question as the lady from the EU Commission here related to the role of policy making. Because yes, while policymakers may change, I think this is in the nature of things. I think policy for healthcare is really important to be consistent and look at the patient outcome. What is the best for our patients? What is the best for the wealth, let's say, of our country? And to that, we are all aware, and I should say that patient journey is difficult everywhere in oncology. There is no such thing as a perfect patient journey anywhere, and I think Andrea here and some other colleagues can confirm that. And we do know that resources are limited. So on that note, and thinking about consistent policies that support oncological patients, my question to you is, knowing what are the key mortality drivers in cancer in Slovakia, would you see a room maybe, and talking about, you know, policymakers in this room, do you think there is time to have a discussion about prioritization, talking about fast track and the green corridor for the patients? Do you think we can potentially open a conversation about what needs to be prioritized?
Thank you very much. I'm sorry, maybe I'm talking too much. On my first graph, I have shown that the mortality rate in Slovakia is almost 100 cases per 100,000 citizens, which means this is a tragedy, and this makes it so urgent that the policymakers will react, and we just need to show it again and again. Those data may not be absolutely reliable, but yes, Anna, go ahead.
To kind of nuance a little bit my question, looking at the main tumor types that are driving the highest mortality within the overall oncological disease spectrum.
Like breast cancer, for example, for Slovakia, I guess. Yeah.
Prostate, colorectal, and things like that.
The question was?
If we should prioritize, for example, breast cancer, that we are clearly behind the other countries in the EU. If we should prioritize some of the cancers first.
Yes, we have identified 3 or 4 cancer diagnoses, which are almost 80% of cancer cases here. Lung cancer, colon cancer, prostate cancer, breast cancer. Yes, we like to address those cases at first, in the first line, first approach, but we need to think further on to, again, widen the spectrum. But yes, you're right, we'd like to start with narrow focus and start with the most frequent cases and hopefully get more support.
Mr. Bystrický, should we prioritize types of cancers?
I think it's kind of double-edged sword. On one hand, yes, you should prioritize when the resources are limited, but on the other hand, you should make sure that you are not gonna put on the, on the back seat some people with other cancers who also needs to be treated and needs to be treated speedily as well. So it's a little bit, for a pilot project, of course, you can select, let's say, a patient with GI cancers and speed their diagnosis, open the waiting rooms for gastroenterologists for, speedier fibroscopy examinations, either upper or lower fibroscopy, and maybe do a pilot project on that, get the pathologists on board who are specializing in GI cancers as a pilot project, but then you still should kind of think about other patients that are there, that they shouldn't be, waiting even more.
Well, maybe this is a better question for prevention, how to focus on prevention of the types of cancer we are worst at. Ms. Bendová, do you think we should prioritize any types of cancers? Maybe prevention. Breast cancer is very
It's for me difficult to see the population point of view
Yeah.
because I'm really working with the patients. I have a mother of 3 children in front of me, and I'm looking forward to help her as much as possible. And I don't think of type of cancer she has. You know, it's not that important from my point of view.
Any other questions from the audience?
Thank you very much. Simon Dres from the European Commission from DG Reform. We are together with IARC supporting Slovakia and Latvia on this project. One brief comment before my question on this question of prioritization. I think one thing is also to look at the distribution of the risk factors and the distribution of participation rates in the screening programs by educational level, by socioeconomic level. Because I think rather than prioritizing between cancers, we see that in Slovakia the variation is really very, very large when we look at tobacco consumption, when we look at obesity, when we look at participation in screening programs by educational level. And that links to my question, which is, thank you for the presentation. I think it's a very interesting program that you're working on. My question is, how do you link with a cancer registry and how do you link with a potential screening registry? Because I think on your chart, you are starting with GP referral after suspected malignancies or first positive test or clinical manifestation. So what about linking with the screening programs? Because then what we found in the project is we have no recall mechanism. We have no follow-up to those who are not participating or who have positive results and are not coming back. And those are very often the ones who cannot because they are working, because they lack the information. So it's exactly those people who are in the lower socioeconomic groups or also in areas of the country that are maybe less well off. So linking with the screening program would possibly allow you to really track those people that are currently falling through the cracks at different stages. So is that planned to link with your program?
Absolutely yes, absolutely and definitely. But if we are about to start a pilot project, which already by itself is so complex and complicated, yes, we have it in the back of our mind. It's not just a back burner. Yes, we are trying to talk to people and to influence them. Look, if you follow the recommendations for screening, we are offering you a good track to get faster treatment. This should support the screening, and also we are planning to definitely connect with the screening programs to get another input, not just opportunistic presentation. I have a problem, doctor, let's go. But yes, doctor will get also the reports from the screening. And on the graph I have shown at 3 separate spots how we report to cancer registry at the beginning from the general practitioner, pathologist, and medical oncologist when the final staging is done. So it's a data collection, screening connection. But yes, in the pilot study, that's why I was talking a little bit narrow spectrum of diseases, because we need to start at certain point and we cannot go too wide, too broadly. But yes, screening absolutely yes, and we are hoping that this will encourage population to participate in the screening, because if you participate, this is what we are offering.
I have nothing to add. Yeah,
Well, maybe part of the question was about the patient and obesity and smoking. So what about the responsibility of the patient? Because we haven't talked about that yet.
That's a very good question. What I'm experiencing in my practice is that Slovak population is very passive. They're coming to us, let's do something with me. They do not take over their own responsibility to change their lifestyle, to quit smoking. They go to X-ray, they ask to go to X-ray, they come with a clear, normal X-ray saying, oh, I can continue smoking, you know? So if you put them on a screening program with CT scans, they might come with the same result. If it's not connected with smoking cessation, there will be not improvement in survival, I think.
I'm a very passionate anti-smoker, so I will continue my work. Another question.
Thank you very much for this fruitful panel discussions, very worthwhile. So Germany is very close to the Slovak Republic problem-wise, definitely. So it was very familiar what you were discussing about. How about data security for your very worthwhile project? Has it been a problem, or is it a problem? Because in Germany, data security regulations, namely GDPR, seems to be an independent risk factor for cancer mortality by slowing down these kind of digital projects. Is it a problem here as well?
So GDPR is slowing down the process?
Yes, definitely in Germany. So we have problems, as you said, linking or using clinical registry data for these kind of projects because the patient consent is not enough. Things like that, what we desperately need in cancer care for quality assurance and improvement.
Yeah.
The whole communication channel will run on a double or triple secured, in a double or triple where which has all the EU certificates, all the international certificates. This was one of the prerequisites before we started talking to companies who would participate. Okay, how do you guarantee the security? And the data security, the safety, and the answer was no hospital, no private practitioner can reach the security level what we have. So this was one I understand, and thank you very much, because most of the bureaucrats come, oh, what about security? How come you want to have the report being moved back and forth? That's what Andre said. The same report will be moving back and forth. Yes, it will be moved, and it will be on extremely secure.
Yes, but that is the data security. But the question was about the GDPR consent, right? Because every time you implement a new system or you share new information, you have to go to the patient and get another consent for another information. That's the GDPR legislation. So how to deal with that?
By now, there is a problem in Slovakia that the doctor or the doctors can share the printed report. The patient can, the doctors will share the printed report, but they cannot share the electronic report. So we are hoping that this will, again, we need to have further approval by the politicians. Hey, if we can share the paper report, let's share it. Yes, we need some legislative change. Yes, absolutely. Thank you for specifying the question.
No problem.
I think the GDPR is an issue, but what is interesting is that GDPR is throughout EU, but each country interpret differently what means data protection. Everybody's looking for data protection. Let's protect the patient data, no question about it. But you have countries that figure out how to share data information, thinking that this is a person that, the GP and the oncologists in the tertiary, they need to understand that he cannot only have the data that he got without the data that she gave to him. So in the public health sector, we need to rediscuss this, how this is interpreted. How can you have in Slovakia that if the patient got you on paper, it's okay to share, but not electronically? So this interpretation, that the data, how you share it, and some countries share everything because it's the patient's right to have a better health, and this means having access to all his health data, and some countries don't share nothing, and it's the same law.
Yeah. So far, we implement GDPR in Slovakia mostly how not to answer questions of journalists on the ministry. So, yeah, that's the main reason we don't get the answers. Okay, any other questions?
Thank you. My name is Michael Stanag. I'm from the National HTA body in Slovakia. We're the ones on the end of the trajectory assessing the drugs coming in. I guess my question is about the realistic time frame. So you say how to shorten the journey. I guess making a comment on Andre's point about the limits on how many screenings, how many MRIs can be done a day. Within a limited budget, there will always be a limit to that, right? So that just will be there. in the Slovak context, what do you expect? How can that be shortened? What is the realistic time frame that you, well, if you pick a specific diagnosis, how long can that take for a breast cancer patient to go from first symptoms to initiation of therapy? Thank you.
The realistic journey.
You were talking about how realistic it is. How do we expect this to work in association with the screening? I don't know. I'm hoping. We cannot predict. We are hoping, we know, and we've heard how difficult it is to have people, even if they have detected blood in the stool, only 40% of those will proceed. We are hoping to have this for them as a chocolate for the screening population. Hey, follow, this is the sweet stuff, let's go there. No, we don't know how many and what is the extent of our cooperation, but we are hoping to get more and more, and I don't know, can you answer it?
We identified really many problems during the journey, and we are at the beginning to do something. Maybe we can do with the communication that we share the records that assists to find the important information, because sometimes I print the report and I highlight in yellow what is important that shouldn't be in 21st century, I think. So also the call center could help, okay, to make appointment for the patient. So there are several steps, and we have to start to improve some of them, which we can influence with this system, with this assistant, artificial intelligence, which we cannot influence. They have to wait, let's say, until the political situation changes or until we find a solution to have enough GPs, enough nurses. Andre?
The magic number, right, and nobody really knows where it came from, seems to be 60 days. 30 days to confirm diagnosis from the suspicions, 30 days to start treatment after. The WHO is using the 60-day for the breast cancer global initiative, and they have some studies that show that if it takes more than 6 days, the prognosis change. But of course, you have some type of cancers that you cannot take 60 days, right? Brain tumors, some of the lung tumors, you miss the opportunity to treat surgically if you take 60 days. And there are cancers that can be longer, right? Some prostate cancers, it's low grow, but the average magic number seems to be around 60.
But it's magic. What about the reality in Slovakia?
Well, we heard the reality, but I think the answer to your question and what you say would be, let's say, if the patient comes with some symptoms, either a mass in the breast or maybe blood in the stool, or so 2 weeks for the appointment for the specialist, then 2 weeks to get the histology. Usually, it takes them 10 working days, so that's 2 weeks. So that's a month already. Yeah. Then you have 2 weeks for the surgery, so that's 1.5 months, and then you have 2 weeks to get a definite histology and to start treatments. So that's those 2 months. That would be, yeah, and I think it would make us all happy. Yeah. If you have those 2 weeks between
I completely understand, but I think that the question was, what is the real number we could get to, like in several years? So target is 60, okay. And what is the reality? Yeah. So what? Are we talking about 100 days, like in 5 years? What is the real goal that we should aim to? Because, as Andre said, we cannot get the perfect situation in 5 years. We have to be real. So what would be your suggestion that the real number is, like, let's say in 5 years?
3 months.
3 months is 90 days. 90 days is closer to 60 than 180 days. Again, I am being called pathological optimist, so I still hope and believe in the 60 days, and we will be aiming for the 60 days at the beginning. The reality may be 90 days. Yes, this is Slovakia. Yes, we need to respect the local environment and the local conditions. But yes, we will be aiming for 60. But yes, maybe realistically, what Andre said and what Branislav said, yes, maybe realistically it's going to be 90. Thank you.
90. Andre, you wanted to add something?
Just a bold estimate, you can drop quickly to 120 just for understand the referral pathway. This is a quick drop. From there on, you need a negotiation to go from 20 to 22 MRIs, but reorganizing, right, give you a drop of a month easily.
Just a brief question. If the time counts from the first symptom, how will you influence the patient factor? Because this cannot be influenced by your worthwhile digital project. So the patient has to come to the GP, has to be aware of the symptoms, which are sometimes not specific, especially in lung cancer. So how do you plan to influence the patient's awareness that it may be cancer?
Yeah, well, I would imagine that text messages would be great, but...
Not really. I think we plan two different ways of entry, ports of entry into the system. A, patient comes for regular annual checkup. He answers the questions in the questionnaire, does not even know that some of the questions will raise the suspicion for cancer. He doesn't even know, but the system will pull it. We know, for instance, pancreatic cancer, just for history, the AI can pull out the indication for pancreatic cancer, which clinicians were not able to do. So we are hoping that the system will pull out the signals from the history and from the questionnaire. The second one, when the patient comes with the complaints, he still doesn't know if they are or they are not a symptom of a malignant disease. The GP may not be sure, but the system will say, yes, with this and these symptoms, GP, be careful, this may be malignancy, consider sending him.
Two things. One is the tradition. The GP here is really the first contact. So if the relationship with the population he takes care of is very good, the patient come with the symptoms, okay, because they trust GP. Either he will say this is nothing, you don't need to worry about, or you have to go there and there. A second is we have a very good system of these preventive checkups which are not annual but biannual. So every 2 years you can go to preventive checkup, which is for free. And the number of people attending these exams is increasing because the health insurance companies implemented a system of benefits. For example, if you need a dentist surgery or something, treatment by surgeon or by dentist, it's not paid by health insurance company if you didn't go to these preventive checkups. So it's really working, these positive incentives to the patients.
I think the one answer to your question is also the health literacy of Slovak citizens, which we need to improve. So that's the problem. Yeah. Because the patient can have symptoms for 3 months or can have symptoms for 3 years almost and comes to the GP when he's spitting blood and lost 20 kgs and it's too late to do anything and he's not fit even for other examinations. So that's one thing, the health literacy that needs to be taught in schools and kind of repeat to the young people and start from the young. And the other thing is the cancer still has a taboo and the patient comes late, and when we asking why did you come so late, oh, I was afraid. What were you afraid of? I was afraid of cancer. So that, get this kind of, get the notion that the cancer is actually curable and doesn't mean a death sentence.
But back to the preventive checkups, we usually see always the same patients coming every 2 years. And there is a portion, about 10%, who I never see, who do not appear. And from my experience, these are the vulnerable population. Alcohol intake, smokers, they know we will find something, okay? So they do not want to know about it, they are not coming.
I missed several checkups during COVID myself, so maybe the COVID didn't help, right?
Beginning we were scared, of course, and the preventive care and also oncological screenings stopped. But then, because of the health insurance company's initiative, we were like overflooded with the patients wanting an appointment because of the dental care. So I think the backup is nearly zero at the moment.
Very quickly, right, you brought attention for one. So the journey delay, you have the patient delay, the professional delay, and the health system delay, right? And we have been talking a lot about the health system delay, right? You brought the patient delay that we need to, but we also need to talk about the professional delay, because we count from the first time that they go for the GP, and that's what we're talking about, counting the journey, because it's really difficult to say when you really start to diagnose and make a very accurate timeline on that. That's what we need to guarantee when first encounter with the health system, right? But we need also to understand that not all health professionals at that point will think about cancer. And that creates some delay there as well, right? So, and I think, work in strengthening the health system, training the health professionals, and patient awareness is a trio that we need to organize to decrease this pathway.
Thank you very much. It was really interesting. Andrej Carvalho, Senior Scientist of International Agency for Research on Cancer. Thank you very much. Branislav Bystrický, Vice President of Slovak Oncology Society. Jana Bendová, former GP expert on Ministry of Health of the Slovak Republic. And Štefan Korec, Chair of OnkoAliance, Slovakia. I hope you are hungry, because we have the lunch break now, and we will see each other at 1 o'clock precisely.